Welcome to the Besties with Breasties podcast. Sarah Hall here. I am a certified health and wellness coach, athletic trainer, mom, and breast cancer survivor. I help women overcome their own mind drama to make mind shifts that open up the possibility for their most empowered and energetic life.
And I am Beth Wilmus, author, speaker, and founder of a human investment organization, otherwise known as a nonprofit, called Faith Through Fire. Our mission is to reduce the fear and anxiety that breast cancer patients feel and replace it with hope and a path toward thriving.
This podcast is about our experiences with breast cancer
and life after as young survivors and moms. Good morning.
Good morning.
How are you?
Good.
Good. We've got a guest today.
Yes. This is another good one.
It's
another good one.
I am looking forward to it because we're talking to Dr. Daniel Thomas, and he's a research-oriented physician with a wealth of education, experience, and expertise. So his career has gone on now for 35 years, and he has helped people from around the world by providing innovative solutions for reversing disease, improving health, and expanding lifespan. So he works with a lot of cancer patients, especially in the later stages of the disease. And I'm going to ask him about this, but he is one of the few physicians I've found that's incorporating PhD research, like scientific research into his practice. And so, we're going to talk to him today about how he practices, how he incorporates research into his practice, what cancer stem cells are.
And their role in tumor growth and recurrence.
Yeah. And just the significance of targeting those for preventing relapse and any advice that he has for patients listening.
Yeah. But before we do that and get to Dr. Thomas, we're going to hear from our first sponsor.
Ann's Bra Shop features skilled mastectomy fitters ready to assist you in selecting the perfect breast forms, bras, swimsuits, and camisoles for your post-surgery needs. They have 3 locations in the St. Louis area, Chesterfield and Winsville, Missouri, across the river in O'Fallon, Illinois, and a 4th location south on I-55 in Cape Girardeau. Visit Ann's Bra Shop at www.brashop.com to learn more. Well, welcome. Thank you so much for being here, Dr. Thomas.
You're welcome.
I'm really interested in talking to you because you have a focus on cancer stem cells. Well, first, let me back up. I thought you were interesting because you are doing something that I don't see a lot of doctors doing, which is marrying research from PhDs and putting it into your clinical practice. Like, do you have thoughts on that? Because that's a big thing that I'm noticing is that we have all of this research being done by PhD scientists, and there's a chasm between what they're doing and what's being put into practice in the medical setting. And I have my assumption about that. I'm figuring it's because, doctors want to see long-term studies, or they want the FDA to approve, or they're reluctant to use existing drugs off label. But you stood out to me because it seems like you're using this robust research that exists and you're incorporating it into your practice today. What are your thoughts about doctors and why they do or don't do this?
Well, that's a good question. So doctors are very much creatures of habit, Beth, and they're very slow to change. And the majority of patients that I see in my practice are stage 4, and oftentimes they're late stage 4 cancer patients. So they don't have the luxury of time to have multiple clinical studies done, before a drug might be proven, effective to be used, as part of standard of care. But the problem is when a scientist or a team of scientists makes a significant discovery, something that to them looks very promising, it takes just under 20 years before that eventually becomes part of standard of care, where it's a routine treatment that all doctors offer. Nearly 20 years. And that's a long time. And people with metastatic cancer, they don't have the luxury of time. So I have to think outside the box. And the majority of reading that I do are science journals. So I have to kind of go right to the source. And then oftentimes I'll develop working relationships with the scientists where I'll contact them, get an opportunity to really pick their brain, to go even a bit beyond just what the study alluded to, and to really work together to try to bring from the lab into the clinic and get a jump start on some of these therapies that look promising. But I don't know why more doctors don't cross the aisle. We could be so much further ahead in the field of cancer or Alzheimer's research or really any chronic disease if physicians would be willing to contact the scientists and say, look, what do you men and women say that looks promising to you? Maybe we should take a look at that now rather than later.
Because I think a lot of people don't understand that as a doctor, you have the ability to, quote, practice medicine, which means that if there is a drug that has been approved by the FDA for whatever purpose, you are allowed to use that drug for other purposes at your discretion. So if there's a study that says an existing drug is on the market that has shown some promise in addressing cancer, you have the ability to incorporate that into somebody's treatment plan. Are you an independent physician or do you work for a hospital? Because that's where I see the difference, is that the independent physicians have the flexibility to do that, whereas those that work for a hospital are employed by the hospital, and therefore they have to adhere to a certain protocol. Is that your understanding, or am I off base?
No, you're right on point, because there'll be certain policies in play when a physician is part of either a group practice, whether they own the practice or whether the hospital does. And so, yeah, they're more restricted. Even if you're, say, a more adventurous physician in the group and more open-minded to these things, it's really difficult for that individual doctor to put into place some of these things. And so I'm kind of a part of a dying breed of a solo practitioner where I just work for myself. Actually, I work with my wife, who's a nurse practitioner plus a PhD scientist. So we're part of a dying breed of just independent. We're not really beholden to anybody.
Huh. That is nice. A dying breed. Yeah, I think more and more people are finding that hard to sustain and are kind of going into that healthcare model where they work for a larger entity. So kudos to you, because I know that's not easy. So I want to dive into kind of what I saw as the basis for how you practice. Is it fair to say that cancer stem cells are the entire reason for metastasis, and that's really where we should be focusing our attention? Because, I mean, metastasis is what we're all trying to avoid, right?
Correct. Yeah, because what kills people is not the primary tumor in general. It's when that tumor decides to spread to a neighboring organ or vital organ, and eventually that's what kills people. So if cancer never migrated, if it always stayed in the original spot where it formed, well, then the treatment would be surgery. You'd remove the tumor and it'd be a done deal. But cancer likes to spread its wings. It likes to metastasize. And yeah, that's generally what causes most deaths from cancer, is the metastatic stage. So if you can really find out what is the main cause of metastasis and really attack it from that angle, you'll be much further ahead.
So how are stem cells related to recurrence or metastasis? Can you explain that for the lay person listening who doesn't really understand how it's related?
Sure. So there's many types of cells in a tumor. It's not just one single cell. You have what are called the bulk tumor cells. These are the main cancer cells that they try to direct treatment to. These are the cells that are dividing and multiplying. Then there's going to be a very small subset of cells, less than 1% by weight of the tumor, is going to be made up of cancer stem cells. And so cancer stem cells are not the tumor cells. They have the potential to become, they're more generic cells, sort of sitting on the sidelines. So they're like a hibernating bear that can come out of their hibernation. But these cancer stem cells are now known to be the main cause of metastasis. So when a tumor spreads from the original spot and decides to go to, say, a neighboring lymph node, those are cancer stem cells that were sent out to that lymph node, and they morphed into a tumor cell. So stem cells have a good purpose. In our body, we have countless stem cells, and those stem cells are lying in wait, and they help the body heal from injury. So say if you break your leg and the bone is set and you're put into a cast, well, stem cells are going to migrate to that area of injury, and they're going to morph into bone cells, cartilage cells, whatever cells that are needed to help that injury repair itself. So that's the good side. But when there's cancer stem cells, those stem cells are only committed to becoming new tumor cells. So they do know it's the main cause of metastasis. They're also the main cause of cancer recurrence. So you can be in remission and have no evidence of disease. You can be in remission for months or maybe years, but if cancer comes back, it's going to usually be because of lingering stem cells that later decided to wake up and morph into new tumor cells. And generally, when cancer returns, unfortunately, it tends to be more aggressive than the first time. So the stem cells, almost like the babies of the mother tumor, so to speak, they're like the children, and they're noticing the whole time what may be causing the demise of their parents, so to speak. So they're learning from the mistakes that maybe the parents made. So if they later decide to become a tumor cell, they're much wiser at that point. That's why when cancer returns, it usually returns with a vengeance. So it's the main cause of metastasis, disease recurrence. Now, the newest thought is, and it's a little bit controversial because it's a new sort of thought process, but there's a number of scientists that are saying, you know what? Cancer stem cells may be the cause of the original tumor. It may have all generated from a cancer stem cell that was once a normal stem cell, but some sort of malignant transformation happened and that normal healthy stem cell became a cancer cell.
Is that where lifestyle comes in? Like, because I mean, I've been told that, we all have the propensity for cancer cells in our body, and it's whether our immune system is strong enough to basically keep it from proliferating. Is that accurate? Is that where lifestyle comes in? Because we see a lot of physicians disregard, a healthy lifestyle. But yet you see data that says that you can lower your recurrence rate by 50 to 60% if you exercise 150 minutes a week. How does that relate, or does it?
Oh, it relates big time. So people that come to see me, they know I'm going to have them make some meaningful changes in their diet and lifestyle. And in my opinion, that's where you should start no matter what disease you're looking to reverse, whether it's cancer, heart disease, or diabetes. You really want to start with diet and lifestyle. That to me is foundational. That old phrase from Hippocrates, let food be thy medicine, medicine be thy food. So that's where we start. But yeah, the more I believe the data is very strong that the more plant-based your diet is, the better you are able to combat existing cancer or preventing its recurrence or just preventing it from even happening in the first place. So yeah, diet and lifestyle are crucial. Even exercise. Exercise has been called medicine. It has a medicinal effect. It has so many health benefits. But yes, diet and exercise and being well hydrated, getting plenty of sleep, spending time outdoors, just all of these things combined and things we all should be doing every day are conducive to good health and becoming more resilient to cancer.
So this feels like kind of foundational, like that, just the stem cell, like the way that you explained it, it's not terribly difficult to understand. And just the sort of foundation of a healthy lifestyle seems sort of simple. Why is this not talked about? And why is it like almost kind of even poo-pooed when it's brought up in the doctor's office?
So I've had patients that will bring this topic up because patients that come to see me tend to be rather savvy. They know how to look up studies on PubMed. They know how to read them. They have a pretty decent understanding of cancer cell biology. So they'll ask their oncologist. They'll say, doctor, help me understand. I know what we're doing to attack the active tumor cells, the ones that are proliferating. But are we doing anything, or can we do anything to also target the cancer stem cells? And a lot of times the oncologist is surprised, say, oh, you heard of those? But then they'll shrug their shoulder and say, well, we're not doing anything. And the patient will say, well, how come? Well, because there's nothing we can do. There is no FDA approved drug for that. So I think that's why they don't bring it up. There's no actual drug that's been FDA approved just for targeting stem cells, at least not yet.
So what's the role of chemotherapy, surgery, and radiation then? If it's not the tumor itself that is harmful, if it's these cells that basically, drift in the body and they have no means to address it currently, what are we doing? What are we doing? Where is the role of chemotherapy and radiation in terms of killing stem cells?
Okay, well, no, it doesn't really play any role, unfortunately. And oftentimes, and the data supports this, not only does it not target cancer stem cells, oftentimes it can cause them to proliferate or to spread.
Is this because they, like you said, those children see like they learn how to get stronger, right? To overcome the therapy?
Oh, exactly. And sometimes they can multiply and be released rather quickly, especially with surgery. So almost imagine like you're a tumor and you're going to be removed, and it's going to be the end of you at that point. So it's telling its children, run for your lives. Your mother may be a goner, but I need to live on through you. Just like we live on through our children, so to speak. Part of us lives on genetically. So that then they can spread just from the invasion of the surgery, and the temporary inflammation from surgery can drive the release of stem cells. So
is there research around that? Because we hear patients who say, I know biopsies and surgery are going to spread my cancer and cause systemic inflammation, which will make me worse. And they are very much dismissed by the medical community as being crazy. But is there medical research to back the fact that, we are causing cells to scatter when we do these surgical interventions?
Oh, absolutely. In fact, excellent research. It's several years old now, out of Harvard Medical School. They found that with women who are having surgery for breast cancer, whether that be a lumpectomy or a full mastectomy, it's very typical for women to get a recurrence of that breast cancer between 14 and 18 months post-surgery. It's very, very typical. And what they do is they try to track women 5 years out from the surgery, because if you can make it 5 years without their cancer coming back, that's kind of considered a cure. Now, it can still come back, the first day of the 6th year, but chances are good that if it hasn't returned in 5 years, it's probably not going to. So what causes that recurrence? Well, it's actually during the surgery. There's so much inflammation that's normal because it's an invasion of the body. So there's going to be a lot of temporary inflammation. That inflammation drives the release of these cancer stem cells that will lie in wait. And around 14 to 18 months, they decide to wake up and morph into new tumor cells. So they found that by doing one single thing, it could eliminate that recurrence at that 14 to 18 months. It was really simple. It was actually to take a drug called ketorolac. Ketorolac is a drug available at all pharmacies. It's an old drug. It's an NSAID. It's a non-steroidal anti-inflammatory. It's somewhat similar to ibuprofen, but it works a bit differently. But they found if women would just take this ketorolac the day before, the day of, or the day after the procedure, even a biopsy, it completely flatlined that recurrence at 14 to 18 months. So it suppressed the inflammation from the surgery, so the inflammation didn't drive the release of these stem cells. This is something and the literature is out there. Now, initially, the few surgeons that read this article or knew about it, their reaction was, yeah, but that's an NSAID. It could potentially increase bleeding risk during surgery. That's the last thing a surgeon wants are complications. But since then, they've done several studies to look at, okay, what is the bleeding risk around surgery by just taking this drug for 3 days? And they've looked at minor surgeries to major surgeries, men and women, different age groups, and they found it did not increase the bleeding risk from surgery. So it's been found to be safe to use in and around surgery. So to me, that's a very cheap, safe insurance policy that you can take out that would protect you from the procedure itself from spreading cancer or creating more down the road.
Wow, that's amazing.
Yeah, very interesting.
Yeah, for sure. Before we jump into more information, let's do Boobs in the News. Boobs in the News is a fun segment where we read funny tweets by real people or ridiculous news stories.
Boobs in the news, boobs in the news, boobs in the news.
Okay, the title says, Attorney's poo-filled Pringles prank leads to suspension.
Gross. I don't even want to know where this is going. I'm making it up in my brain and I don't like it.
Okay, so I'm not going to give his name. I don't know why I feel bad giving his name.
Yeah.
But he's a criminal defense.
It was his prank.
He's a criminal defense attorney in Ohio, was suspended by the Supreme Court of Ohio from practicing law for 1 year.
Good Lord.
With 6 months of that suspension stayed. His crime, tossing a Pringles potato chip can full of his own feces in the parking lot of a victim advocacy center and failing to control his own bizarre impulses.
I mean, what did they do to him?
I don't know. It says on the morning of November 30th, he defecated into an empty Pringles can and then left his home to attend a pretrial hearing for his client, who was a defendant in a capital murder case. Okay, so his client's on trial for murder. However, as he drove past the Haven of Hope Victim Advocacy Center, which was scheduled to appear in court opposite of him in the trial, he threw the Pringles can into the parking lot before heading to the courthouse.
Oh my gosh. This guy better be in anger management.
This guy,
He's got to work on his outlets.
Yeah, so somebody who worked at the advocacy center saw the incident and reported it to the police, and then they had him on surveillance video. Can you imagine? So he says he wasn't targeting anyone in particular, but rather that he had thrown the feces-filled can to blow off steam.
There are other ways to blow off steam.
Now I do want to give his name. This is bizarre.
Yeah.
He also admitted that he had pulled the Pringles prank at least 10 times that year. He's a repeat offender.
First of all, he's got a Pringles problem. And second of all, pooping in a Pringles can?
Really gross.
That is so weird.
And
I mean, that feels like a weird fetish.
That's a weird fetish. There's something weird going on there. Like,
to
blow off steam. And, I mean, think about how accurate your aim has to be to get a freaking poo inside the...
Well, I mean, you're putting it right on there.
I mean, but it's just... I would think it'd be really hard. You got to spread your cheeks. You got to sit on the can.
Yeah, that's a tiny hole. I mean, he's going from one tiny hole to another.
Right. I'm just saying, like, your accuracy better be dead on. You know that guy's like, I hope he washes his hands. That's all I got to say.
And what did he do it in the bathroom on the way over before he went over, or like in his car? Because that whole picture in my brain sounds even more gross.
Maybe this is a mental health issue. This man,
I
mean, he definitely shouldn't be practicing. Like, I think that they definitely needed to suspend him.
Definitely.
But
you just said definitely like 3 times. I couldn't help myself.
But they should have mandated counseling. Like there's no mention
management for sure.
There's no mention of that in there.
Definitely.
Oh, I love it. There's your boobs.
Boobs in the news. Boobs in the news. Boobs in the news. All right. We are back from Boobs in the News. Interesting stuff you're sharing. And Beth and I actually both listened to your course before we hopped on with you because we wanted to make sure that we were up to date on everything, which you share so much good information in there. So you say in there that when you're tumor-free, it's not actually the same thing as being cancer-free. So isn't
Correct.
that what chemo is really supposed to do? I know that there's going to be a lot of people listening who have this, they think they have their own insurance policy. The fact that, I did everything and I did everything that I was supposed to. But, what can they do now that they're on the other side if they've chosen all those treatments?
Yeah, I mean, like, what do you think and what do you think needs to change in cancer care?
Yes, you bring up a really good question and point. What is the endpoint of treatment? Is being tumor-free the same as being cancer-free? And it's not the same, because being tumor-free just means that either your tumor marker, if there's a blood marker that will track your tumor, or the scan doesn't show any disease. And they call that NED, no evidence of disease or complete remission. But that just means that they can't see anything on the scan. Doesn't mean there's not cancer there, because stem cells are individual cells. They're not clumped up and they're not big enough to be seen on a scan or to make a tumor marker go up, because they're really not cancer yet. They have the ability to morph or become cancer. So the purpose of contemporary cancer treatment, the way it is now, whether it's chemotherapy, surgery, or radiation, or targeted therapy, is to get you to the point of being tumor-free. And it'll buy you some time for sure, but it's sort of a stopgap measure. To be cancer-free, you really have to say, okay, what is in my body that can become more cancer? You have to really target that, because if you can do that, then that maybe elusive cancer-free state maybe can become possible. And I'm not claiming that I'm making patients cancer-free. That's a bold statement. But I believe we can get closer to that point if we really make a concerted effort, use all the available data to simultaneously target cancer stem cells. Then you will get longer-term, better outcomes, longer states of remission.
What do you think needs to change in order for this to happen? I mean, as a patient, you just feel so helpless and you're at the mercy of the existing system. How would you encourage people to move forward in their care and to advocate for themselves and to really, push to get the best possible outcome?
Well, you can be your best advocate because doctors, especially ones that are a bit younger, are more open-minded. They're not as stodgy or set in their ways just because they're younger. And I would become fairly adept with looking up and finding studies on PubMed, printing a copy of the study, bringing it to the doctor and saying, "Doctor, could you read this article? I'm really curious. It sounds like this is something that could be beneficial to me or might apply in my case." And really try to open their eyes. Sometimes your doctor may be more open-minded than you think. They just don't want to feel like they're the only ones that would be going down this road, that of something that's completely untested. If you could actually show them some published data on something, especially if it's already an FDA-approved drug, it's not something that's going to be unknown or side effects that are unknown. I mean, that's the advantage of using a repurposed drug. It's like an old familiar friend. We're pretty familiar and know what to expect with it. So I would be pushing and printing articles and bringing them to your doctor. That's why I do a lot of writing, and I submit topics to different Facebook groups like Jane McClellan's How to Starve Cancer.
We interviewed her right before you.
Oh, okay. Yeah, I know Jane well. She's a sweet lady. She had her own battle with cancer, and she spent a week at her office a couple of years ago, and we got to know her really well. But to really, get familiar with, not that you have to become a cancer scientist in training, but at least to become familiar enough where you can get these studies or even download some of the things that I write to a group. I try to educate people in order so they can bring that information and share it with their own doctor. So that's really kind of where you want to start.
You make a good point, because I think people don't know that a lot of times these oncologists are seeing upwards of 20 patients a day sometimes. And the way the system's set up and the amount of documentation that they're required to now participate in, it really doesn't leave them a ton of time with A, patients, or B, to do their own research on these things. So I agree with you. We had a patient recently that told me that they wouldn't even come in with the study. They would challenge their doctor and say, "I would like you to look into research on stem cells, cancer stem cells, and repurposing drugs, and let me know what you find." And it kind of forced his hand to go and do the research and then come back and kind of tell the patient. And I thought that was really interesting because, to your point, I think it makes more sense to bring him the study, right? Make it as easy on him as possible. But I just thought it was an interesting approach to try to get them thinking outside the box and really making them investigate each patient as an individual instead of this thought process of this is how we treat this group of patients, because we know that there's individual factors that influence how people respond to different things, right? I mean, we've seen success in repurposing existing drugs, but maybe one drug works better for somebody than another. And have we lost that individual approach to care? I mean, that's kind of what patients feel when we're talking about medical skepticism, is that, you know, these large studies that everybody's so fond of group all these people together saying they're similar, but are they? And is care really individualized to that particular patient's history, physiology, and lifestyle?
Yeah. Well, here's the thing. I think we can encourage our doctor, and just the way you say it, say, doctor, I'm so glad that you're on my team, but I so want to get better. I want to do whatever it takes. And I know you want me better as well. So could you please read the study? Because I think it could really help. The way you say it could really sort of tug at their heartstrings. Because look, you know, when I was a kid, doctors were considered scientists and healers, right? I mean, there was sort of, being a physician was like you were a scientist because you had this like unquenchable childlike curiosity about the human body, fascinated by the body's inner workings and always wanting to know more about how to get the body to work better. So bring out that childlike curiosity that the doctor probably at one time had. and then healer is, well, to me, a healer is you do whatever it takes to get your patient better. That's what a healer does. So sort of like draw out from the doctor the love of medicine that they probably still have that just needs to be kind of pulled out, and maybe get them excited about some of these findings from scientists. I think you'll be probably more pleasantly surprised than you will be disappointed if you take that approach with your doctor.
Oh, I love that.
Great advice. Great advice. Before we wrap up with your final words, let's hear from our second sponsor.
Thrivent is a proud sponsor of Faith Through Fire. Thrivent believes money is a tool and not a goal. The Gateway Financial Group with Thrivent is local to the St. Louis area and can work with you to create a financial strategy that reflects your priorities and helps you protect the things that matter to you, like family and giving back. Please call 314-783-4214 to schedule a free consultation with one of Thrivent's Gateway Financial Advisors. All right. So, Dr. Thomas, thank you for being with us today first, but I would love to hear any kind of final words you have for our audience, and then also make sure to let them know how they can find you.
Okay. So I guess the best advice would be the words that Charlotte Gerson used to give to people. We got to know Charlotte Gerson really well, my wife and I. Years ago, we spent a month at the Gerson Clinic down in Mexico. This is back in 1986. So we would drive across the border with Charlotte each day from San Diego. But she would always talk about when she would speak, she had a lot of speaking engagements. And afterwards, people would come up, oh, Miss Gerson, if I ever get cancer, I'm going to come down to your clinic in Mexico. And she would say kind of sternly but nicely, oh, you didn't listen to what I was saying. I want you to prevent cancer, you know, because she would talk mostly about diet and lifestyle. So hopefully you don't need to come see me. So that would be my message, is the way we're going to conquer cancer ultimately, or Alzheimer's, is we need to really prevent our way out of this problem, so to speak. We really need to take a proactive role and really take our diet and lifestyle seriously, because what we do does matter. It absolutely makes a difference.
Awesome.
Oh, that's so good to hear.
And where can patients find you?
Our main website is going to be healthyandstrong.com, or they can go to newhopeforcancer.com. So either one will lead you to the same website. It has more about my background and the approach that we take. But probably the easiest one to remember is newhopeforcancer.com.
And where are you located?
Just outside of Orlando. We're in a small town, a quaint town called Mount Dora.
Okay.
And it's just about 45 minutes from downtown Orlando, Florida.
Perfect. Well, thank you so much for being here. We really appreciate your time.
Oh, it's my pleasure. Thank you very much for having me.
All right. Until next time, guys.
See ya. Thank you for being a listener of the Besties with Breasties podcast. If this podcast had a positive impact on your journey, leave us a review or consider becoming a supporter. You can donate with the link in the show notes or at faiththroughfire.org. This episode was hosted by Sarah Hall and Beth Wilmus, audio and production edits by Innovative Frequencies.